Hi everyone, thank you for joining us today for another scientific webinar series. Today we're going to be talking about model-based DDI extrapolation strategy from adults to children. And this case study is Risdiplam. It's actually quite a nice follow-up. If you caught our previous webinar, which is just recently uploaded on YouTube, the speakers from OCP and FDA gave a bit of an introduction to this, and now we're going to a real deep dive into this recent publication from Yumi and Michael from Roche. So if you just click onto the next slide. So the only other part of the admin here I'll just introduce is about questions. So the way that this webinar is going to work is Yumi and Michael are going to present, and there's a questions feature that you can utilize to ask your questions, and at the end of the presentation we'll put them to Yumi and Michael. Yumi and Michael are obviously very modest. They didn't put much information on the slide when I asked them to do bios, but I think that kind of reflects the fact that they are well known anyway, and very modest people. They have over 15 years of experience in PBPK, population PK and PK/PD modeling, and they obviously are affiliated not only with Roche but with CAPCA at University of Manchester. So obviously they have some good roots there, and Michael is well known as well for looking at intestinal metabolism, which is an important part of this project as well. So with no further ado, I'll just pass on to Yumi, who's going to take us through the first part. Thank you.
Thank you very much, Ori. I hope everybody can hear me well. And so my name is Yumi clearly, and Michael and I are going to talk about model-based drug-drug interaction, DDI extrapolation strategy from adults to children with a case study of Risdiplam. So there is increasing awareness that the DDI in children can be different from adults. And so the theme of our talk today is about how we can evaluate DDI risk in pediatric population to provide guidance for concomitant medications. I would like to start with introduction of spinal muscular atrophy, SMA. SMA is a severe genetic disease. Survival of motor neuron, SMN protein, is an essential protein to sustain our lives. But these patients do not have a functional SMN1 gene, and due to insufficient level of SMN protein, they lose motor neuron functions and develop muscular atrophy over time. There are 3 types of SMA, and the most severe form is a type 1 SMA, with the typical onset of symptoms at around 6 months or younger. And these patients are never able to sit without support, and many of them would die before 2 years of age, mostly due to respiratory failure. So Risdiplam is the first orally available treatment for SMA, and it has been approved for SMA patients 2 months and older in the United States, EU, and other countries since August 2020. It increases SMN protein by modifying splicing of SMN2 messenger RNA. And after oral administration, it distributes into central and peripheral tissues. Risdiplam is a substrate of CYP3A and FMO3 enzymes. In vitro DDI investigation found a time-dependent inhibition, TDI, of CYP3A for both Risdiplam and major metabolite M1. Since Many pediatric patients are expected to receive risdiplam treatment, and many of them take other medications, including CYP3A substrates, to treat their symptoms. So it was important to evaluate TDI in pediatric patients. However, conducting a DDI study in those vulnerable pediatric population was considered unethical. And instead, we have prospectively planned a model-based CYP3A TDI risk assessment with focus on pediatric patients before new drug application to inform drug label. So this figure here summarizes steps we have taken for the TDI risk assessment. A PBPK modeling took a central role in the strategy. And after in vitro DDI investigations, we used those PBPK model to assess clinical relevance. And since this assessment warranted clinical DDI investigation, we conducted a study in healthy adults. And here we have used the PBPK model to support study design for the DDI study to be informative for pediatric population. And the study result and the PBPK model were used to estimate in vivo TDI parameters. And estimated in vivo TDI parameters were then applied in the pediatric PBPK model to extrapolate the DDI to pediatric population. In order to assess impact of uncertainty in enzyme ontogenies and the drug-related parameters, we also have performed sensitivity analysis to have an overall DDI risk assessment in pediatric population. Time-dependent inhibition of CYP3A was discovered in vitro study with human liver microsomes. Risdiplam and its major metabolite M1 showed a similar potency to inhibit this enzyme. And when we applied in vitro TDI parameters in the PBPK model of risdiplam and used a prototypical CYP3A substrate, midazolam, as a victim substrate, then the PBPK model predicted about 2-fold increase in AUC in adults and 2.5-fold increase in midazolam AUC in pediatric population. This warranted a clinical DDI investigation. So we decided to do a study with midazolam in healthy adults, and we have prospectively planned the PBPK model-based approach for pediatric population. And the PBPK model simulations supported the clinical DDI study design to ensure that the DDI would be investigated at relevant risdiplam exposure in children. So after 14 days of treatment with risdiplam, midazolam AUC was increased by 11% in healthy adults. So this was considered not clinically relevant. So risdiplam appeared to be much weaker inhibitor than the in vitro study suggested. So the question was, what about in children? And how can we extrapolate these DDI results to a pediatric population older than 2 months of age? So we started analyzing the clinical DDI data. We performed the standard non-compartmental analysis to evaluate extent of increase in midazolam Cmax and AUC, which were about 16 and 11% respectively. In addition, we have also performed the population PK modeling to utilize all available plasma concentration data of midazolam to identify the site of interaction. And covariate search identified 11% increase in midazolam bioavailability by risdiplam, but it did not detect effect on clearance. So the POP-PK analysis suggested that the DDI is predominantly presystemic, and the lack of effect on clearance suggested that this is mostly in the intestine rather than the liver. This slide here summarizes a PBPK model of risdiplam. The model was initially developed by bottom-up approach. A mechanistic absorption model predicted almost complete absorption after oral administration of solution. And moderate distribution was based on preclinical study data. Elimination is mostly through hepatic metabolism via a CYP3A with 20% of contribution and FMO3 with 75% of contribution. Renal clearance accounts for about 5% of the total clearance, which was based on the observations in healthy adults. After verifying this model with the healthy adult PK data, then we extended the model to SMA patients. From SMA patients, we have collected relatively sparse samples, so we analyzed them by population PK modeling to characterize ADME, disease-dependent and age-dependent processes. We also developed a specific demographic model for SMA patients to support PBPK modeling. A comparison of post-clearance estimates by the population PK model, we have identified that adult SMA patients have about 30% lower clearance than the healthy adults. So we have adapted intrinsic clearance and renal clearance value in the PBPK model by 30% to reflect this observation. And also, distribution of post-clearance estimates in pediatric patients against age guided us to select an ontogeny function for the clearance. And for our case, a Euclid function for CYP3A was selected and applied for both CYP3A and FMO3. Demographic model can be influential in PBPK modeling because demographic model defines the physiological parameters such as organ sizes and organ blood flow. So if data is available, it would be ideal to develop a tailored demographic model for the target patients population. And in our case, we had data from 466 SMA patients aged between 2 months and 61 years. So we could use this data to develop a specific demographic model. A body height model was according to Jolicoeur, and the body weight model was according to SimSip version 18. And the estimated population and residual error parameters were then implemented in SimSip version 18. And by doing so, we could recover the distribution of height and body weight across the age range, as we have seen in actual patients' population. Risdiplam PBPK model was developed with data collected from 130 subjects. From the healthy adults data, we first characterized ADME. And then when we got data from adult SMA patients, we included disease-dependent process. And from the pediatric SMA patients data, we have included age-dependent processes. And later, we have collected more data from additional 400 subjects, and 300 of them were pediatric SMA patients. So we could use this large and independent data for model validations. As you can see on the right-hand side, that a plasma concentration of risdiplam in healthy adults, which were not included in the model development data set, were reasonably well predicted by the PBPK model. And also, AUC of risdiplam at a steady state in 300 pediatric SMA patients 2 months and older were also adequately predicted by the PBPK model, which was developed on relatively small data set. So this validation step with the large and independent data set gave us confidence in the PBPK model to apply for DDI extrapolation. So the validated PBPK model was then used to estimate in vivo TDI parameter from the clinical DDI study data. Since in vitro TDI parameters predicted about 2-fold increase in midazolam AUC, which appeared to be over-prediction of potency, we had to decrease K-NACT value to capture the observed midazolam Cmax and AUC ratios. So 10-fold reduction was needed to capture observed Cmax ratio. but this still resulted in overprediction of AUC ratio. So we have further decreased the K-NACT value by 18-fold to recover observed midazolam AUC ratio. So with the 18-fold reduced K-NACT value, the PBPK model was able to predict midazolam plasma concentration time profiles in the presence of risdiplam reasonably well, as you can see on the right-hand side. Also, this estimated in vivo TDI parameters gave us some additional insight. The PBPK model predictions indicated that the inhibitory effect is mostly in intestine, with the reduction of intestinal CYP3A by 20%. In the liver, the estimated simulated hepatic CYP3A reduction was about 3%, which was considered negligible. So this is consistent with what we saw in the population PK analysis, which identified intestine as the major site of interaction. This also indicates that the DDI risk for a CYP3A substrate would be negligible if it is given by IV route. And even when substrate with low intestinal availability is given orally, we would still expect increase in bioavailability to be limited up to 25% based on QGAT model. So all in all, a low TDI was suggested by the estimated in vivo TDI parameter. Now, moving on to extrapolation of DDI to pediatric SMA patients. First, we have evaluated hepatic and intestinal CYP3A ontogeny function because these are key physiological input data to define sensitivity to CYP3A modulation in pediatric population. For hepatic CYP3A ontogeny, we have looked at EVRYSDI and Salem functions. So on the right-hand side, you see a blue curve which shows EVRYSDI function. It describes a rapid increase in activity and exceed adult level in some time in the childhood. The yellow line shows Salem function, which shows a rather slower increase in activity with age compared to EVRYSDI function, and it does not exceed adult activity level. For the intestinal CYP3A ontogeny, we have looked at the Johnson function and also created additional scenario where we assume the full maturity at birth. And we conducted validation of a midazolam PBPK model supplied in SimSwift version 18 using number of publications on clinical PK of Risdiplam. And we have focused on evaluation of hepatic and intestinal CYP3A ontogeny functions. Since the site of interaction for Risdiplam is intestine, intestinal CYP3A ontogeny function is the key physiological input data for extrapolation of DDI. The Johnson function was derived based on in vitro data. And as you can see with the green line in the panel below, that it starts at about 50% of adult activity at birth, and then it gradually increases in activity with age. The other scenario with full maturity from birth, which you can see with pink dotted line in the panel below, is to address uncertainty in age-related development in intestinal CYP3A, permeability, and intestinal blood flow. So when we apply Johnson function to midazolam model, then the predicted FG value across the age is constant at around 0.6. And when we apply full maturity function to the midazolam model, then the predicted FG value is lower in children younger than 5 years of age. This is a reflection of a higher abundance of intestinal CYP3A compared to Johnson function. And this younger population represents as a population with higher sensitivity to intestinal CYP3A modulation. We have looked at midazolam clearance, plasma concentration time profiles, and oral bioavailability for the validations. And this is one of the works where we looked at the plasma concentration time profiles. Bartin et al. And Fang Hoen et al. Published a population PK model of midazolam after IV or oral administration in pediatric population. So we use those population PK model to evaluate the PBPK model simulations. And for the simulations, we have used identical distribution of age and the body weight between the population PK and the PBPK model simulations. And for the PBPK model simulations, we have used both Salem and EVRYSDI for hepatic CYP3A and Johnson function for the intestinal CYP3A ontogeny. And as you can see in those four panels, that PBPK model predictions generally showed good consistency with the population PK simulations. And in some instances, EVRYSDI function achieved almost identical plasma concentration profile as simulated by the POP-PK model. But in the other instance, Salem function worked better than the EVRYSDI function. There is a debate about choice of ontogeny function for CYP3A, either Salem or EVRYSDI function or the other. And there is currently no consensus on which function to be used for CYP3A substrate. And from our validation works, it was also difficult for us to say which function works better than the other functions. So for us, it was important to investigate both ontogeny functions for DDI predictions to assess impact of uncertainty around CYP3A ontogeny functions in the DDI prediction in pediatric population. Fg of midazolam is the critical drug-dependent parameter for risdiplam. However, it is not possible to directly observe Fg in pediatric population. So what we did instead was to look at the oral bioavailability of midazolam. And here we have identified 3 independent clinical studies where oral bioavailability of midazolam was investigated in pediatric population. And we performed simulations for midazolam oral bioavailability using various combinations of ontogeny functions. On the left-hand side, you see a simulation with a combination of Salem and Johnson functions. And the model was able to recover observed midazolam oral bioavailability reasonably well. But when we switched from Salem to EVRYSDI function for the hepatic ontogeny, hepatic CYP3 ontogeny, then the model tended to underpredict midazolam oral bioavailability. And further, when we switch from Johnson to full maturity function for the intestinal CYP3 ontogeny, then the extent of underprediction became even larger, that the model was not able to capture any of the observed oral bioavailability. So here we have identified that the combination of EVRYSDI and full maturity is a representation of a very conservative and highly sensitive scenario on the hepatic and intestinal CYP3A ontogeny, which is even rather unrealistic because it could not capture any of the currently available observations. So in other words, if the predicted DDI in children with this combination of ontogeny function is negative, then we would have a high confidence that clinically relevant DDI would be unlikely. So finally, we have extrapolated a DDI to pediatric population receiving risdiplam. And we have used 18-fold reduced K-NACT value from the in vitro estimates. And the EVRYSDI and Johnson functions were used for hepatic and intestinal CYP3A ontogeny. And as you can see below, that predicted midazolam AUC ratio was constantly below 1.25 across the age range, and the 95th percentile was below 2-fold. And the sensitivity analysis were performed for the ranges of hepatic and intestinal CYP3A ontogeny functions and K-NACT values. And even with the most conservative scenario, the 95th percentile of the predicted midazolam AUC ratio was still well below twofold. So based on the extrapolation and sensitivity analysis, we concluded that a clinically relevant DDI in pediatric patients 2 months and older treated with risdiplam would be unlikely. So we have also qualified pediatric DDI predictions. And we identified several literature on DDI extrapolations using PBPK model. And for the in vivo TDI parameters, we performed a population PK analysis to identify site of interactions and estimate for the in vivo K-NACT values. We have given it as a range based on observed Cmax and AUC ratios. We also performed the sensitivity analysis with 25 to 50% higher risdiplam doses than the approved. And even with those higher doses, the resulting prediction was still below 1.5. So this gave us additional confidence that TDI risk in children would be low. In our case, intestinal concentration is the operational concentration for DDI prediction. And the mechanistic absorption model predicted almost complete absorption. And our assumptions on unbound fraction in an enterocyte was 100%, so which lead to almost the highest possible intestinal concentration. And that again ensures conservative perpetuator DDI prediction. As I showed before, we have also taken rigorous evaluation of hepatic and intestinal CYP3A ontogeny functions for the DDI extrapolations. So in summary, we have extrapolated CYP3A TDI from healthy adults to pediatric SMA patients by combining carefully designed clinical DDI trial and PBPK modeling. The PBPK model predicted that CYP3A TDI risk in pediatric population would be negligible. And this predicted low TDI risk by the model has informed the drug labels. For instance, approved US label has the following description. Based on PBPK modeling, a similar increase is expected in children and infants as young as 2 months of age. As a consequence, there is no limitations in concomitant use of CYP3A substrates in adult and pediatric SMA patients. In EU label, there is no mention of PBPK modeling. However, our proposed label without limitations in concomitant use of CYP3A substrate independent of age of patients has been also approved. So in overall, our extrapolation work gave us confidence that CYP3A TDI risk in children is low, and this has informed the drug labels in slightly different forms in various countries. With this, I stop my talk and I hand it over to Michael. Thank you.
Thank you. Thank you, Yumi. We wanted to also take the opportunity before we go to the Q&A to emphasize some of the more general aspects of the extrapolation of DDIs that we have learned from our case example that you can hopefully apply to future DDI projections. So the first one and the most important physiological parameter is, of course, the ontogeny of the enzyme that is affected. In our case, the CYP3A in the liver, but also in the intestine. And as Yumi has pointed out, using midazolam data in our validation of the midazolam as a probe substrate for CYP3A in the liver and in the intestine, we found that it's actually difficult to differentiate the Salim and Upreti function and to come to a conclusion which of the two is the more appropriate function for very young children. And therefore, we selected to look into both. What we couldn't see very clearly in the case of Risdiplam, because it is such a weak inhibitor of CYP3A, was the real sensitivity that these two ontogeny functions have. And in order to address this, we therefore looked into a scenario of a hypothetical potent CYP3A inhibitor, which would give us a certain theoretical AUC and FG ratio. And the AUC and FG ratio can be defined with the two equations that we have here on the screen. Assuming that we have 95% inhibition in the liver, and assuming that we have complete inhibition of CYP3A in the small intestine, given the typically higher concentrations of the inhibitor there, the typical AUC ratio equation can be simplified to the one that is on screen, introducing really the two main factors that drive the DDI of the victim, which is the FG and of course the FM CYP3A4. And if we focus in the first instance on the figure on the left-hand side, you can see the AUC ratio, the projected midazolam AUC ratio across ages. This AUC ratio includes both the hepatic and the intestinal contributions. And we show the Salim function in combination with the Johnson function for the intestine, or in the black circles, the EVRYSDI function in combination with the Johnson function for the intestine. And what is apparent is that for adolescents and adults, the two functions give very similar sensitivities to a potent CYP3A inhibitor. But as you go to younger and younger ages, the two functions start to become dissimilar, and the EVRYSDI function being the more sensitive one, or leading to the higher predicted AUC ratios. And this, as Yumi had pointed out earlier, is due to the steeper maturation of CYP3A4 if we consider the EVRYSDI function for the ontogeny. On the right-hand side, you see the theoretical FG ratio. And here we look into two different functions, the Johnson function, for which we have data and which is based on the in vitro data, but also the full maturity kind of a scenario that we investigated in our example. And here again, what we see is that both functions give us a very similar DDI for adolescents and adults. And again, the most vulnerable population, the very young children, show the strongest differences, such that, as Yumi had pointed out, the EVRYSDI function for the liver and the full maturity function for the small intestine are the most sensitive and the most conservative scenario that we could investigate. The second question that we would like to address in more general terms is, what about minor pathways? We talked a lot today, and we generally as a community talk a lot about CYP3A ontogeny and how to derive it. But what about the minor pathways? In the case of midazolam, this minor pathway is the direct glucuronidation by UGT1A4, and it is minor in adults. About 2% of the total metabolism goes via this direct glucuronidation pathway. And the figures that are shown here represent what Yumi has introduced earlier already. They're just a duplicate. In blue, you see the EVRYSDI function, and in yellow, you see the Salim function for CYP3A.
Looks like we just had a little bit of a technical snafu, but we'll be back in a sec. Thanks, Pam.
Yeah, so if we now add to these CYP3A ontogenies also the UGT ontogeny, there are two possible scenarios or two different ontogenies that have been used in the past. The one on the left-hand side is the most recent implementation that you will find. And this shows a relatively steep progression of UGT1A4. So the value starts pretty close to 0 at birth, and then relatively steeply approaches the adult level. Whereas the second possible ontogeny for 1A4 has a very different profile. It already starts with a higher activity at birth and then also matures towards the 100% of adult level, but the changes are much more gradual in this function. And for us, the question is, of course, well, what is the sensitivity to the DDI in this context? And the sensitivity to the DDI you can see here again as the theoretical AUC ratio, including both the hepatic and the intestinal contributions. What is striking, the figure on the left, the bottom left, is what I showed you on the slide before. But now I can explain a little bit more why the Salem function gives us such an age-independent DDI risk for a CYP3A4 inhibition. It is simply because, looking at the figure on top, the Salem CYP3A ontogeny and the UGT1A4 ontogenies have very similar profiles, which leads to a very similar FM value of midazolam across the ages, and therefore the theoretical AUC ratio is very, very similar. In contrast, the Upreti function would be steeper or is steeper than the UGT1A4. This means that children of younger age have higher FM CYP3A4 values, leading to this higher sensitivity. But if we look at the figure on the bottom right-hand side, you can see that there might also be a scenario where children might be at a lower risk. And this is the case if, for instance, the minor pathway contributes relatively more at the beginning of the development of a child compared to the victim enzyme. And therefore, we think that inclusion or understanding of the minor pathways is very relevant, because even though the contribution might be very small, the sensitivity is very strong, especially when the FM value approaches 1, and then 1, 2, or 5% might make a very significant difference. Okay, and this brings me to our general conclusions. Developing specific demographic models for us has a real opportunity to make sure that we capture the demographics of the patient population that we are studying, and that leads to downstream aspects that are relevant for the PBPK model. We suggest to use validation and qualification wherever possible with independent data. And this is particularly important in our view for the ontogeny functions, to derive or to contrast the ontogeny functions that are available, either using the literature data or emerging data from clinical studies. It is also really important to evaluate the suitability of the victim drug. And Yumi showed this very nicely at the example of midazolam, but this is equally true for other victim drugs. Of course, those data are very sparse, and we need to be really mindful when we generate those data that we can actually use them most effectively. And this is equally true also for the TDI or competitive parameters that we might derive from clinical data. For this part, we usually use the NCA, but I think in the future we should be using much more PBPK, population PK, or a combination of the two, population PBPK, in order to make sure we get the appropriate parameters and we are able to include the uncertainty that we have in our estimates appropriately in the future projections. Yumi showed very nicely that using a population PK model on midazolam allowed us to identify the site of action and then confirm this later using PBPK modeling. So this again is for us a really strong benefit that combining PBPK and population PK approaches can bring. And lastly, I think as a community, we need to really work on deriving the ontogenies, validating the ontogenies that have been derived from our data sources or from other literature sources, and to include, wherever there is no consensus, to include different functions in order to assess the sensitivity that the different functions have on the FG and AUC ratios that we project. Okay, and with this, I would like to thank our collaborators and co-authors at Roche and the University of Manchester. We would also like to thank Karen and Trevor for their insightful comments on the manuscript and this work overall. And with this, I would conclude our presentation and open it up for questions.